Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki ekoweshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
So good morning, everybody, and welcome to the April edition of Family Medicine Ground Rounds. Happy Earth Day. My name is Doug Archibald, and I'm the Director of Research and Innovation for the Department of Family Medicine, and thanks for joining. Today's session comes to us from the Civic Melrose Group, and we have 3 presentations. So without further ado, I will introduce our first speaker, Dr. Anna Wilkinson, who's a family physician with a special interest in oncology. She divides her clinical time between caring for medical oncology and patients and academic family medicine. Anna is responsible for the PGY3 FP Oncology program and is the chair of the Cancer Care Member Interest Group with the CFPC. She has recently become the Regional Cancer Primary Care Lead. Anna's special interests include knowledge translation of oncology to family medicine residents and practicing physicians. And in her spare time, she tries to keep up with her 4 athletic daughters. So, Anna, I turn things over to you.
Good morning, thanks. So I'm just going to share my screen here for a second. Great. So I'm thrilled to be here on this snowy spring morning. It was certainly a bit of a shock looking out the window this morning. I'm going to talk to you about what's your cancer IQ and the work I do to try and support family doctors in their care of cancer patients. So, cancer and family docs. Sometimes when I start to talk about cancer to family docs, they get this kind of glazed look over their faces, like, why should I care? Cancer, it's this, the cancer center, it's this big black box, it's scary, there's all these strange drugs. But the bottom line in cancer and family medicine is that 40% of Canadians will develop cancer in their lifetime. So, almost half of your practice is going to have this. 30% of Canadians will die from it. So 1/3 of your patients will die from cancer. And as family docs, we screen for cancer, we diagnose it, we support and advise patients during their treatment. and we do survivorship care. So really, as a family doctor, if you have a higher cancer IQ, you're going to be able to look after your patients better. The bottom line, though, is that family docs actually don't know very much about cancer often and are not receiving a lot of training. So a recent survey of 16 of the 17 family medicine residency programs showed that only 7% of residents felt adequately prepared to care for their patients with cancer. So that's a pretty low number. So my sort of goal in life is to try and increase that number from 7% to more than that, so that we're doing a good job for our patients. So this morning we're going to do a little quiz. I thought I'd try and make it interactive and interesting. So we're going to figure out what everybody's cancer IQ is. And I'm going to use poll everywhere. So if you can see at the top, there's two ways to kind of log in. You can use the text method or the link method. So I don't know if people can try and get logged in there. So the first question here, we're just going to do a few questions to kind of gauge where we're at. So the number needed to screen to prevent one death from lung cancer when we're speaking about low dose CT is what? 120, 250, 380, 723, 1312. And the optimal number to screen for context for breast cancer is 645. So I don't know if people are able to get on and vote there. Oh, okay, I'm starting to see. Okay. We'll just give it a little bit of time and get people logged on. Are people, I can't see the chat, so I don't know if people are having troubles logging on. So while we're waiting, I'll just talk a little bit about about lung cancer screening. I don't know if everyone knows, but as of April 1st, we now have a formal lung cancer screening program. Before this, we were a pilot program. There's 4 sites in Ontario, and Ottawa is one of these sites. So you should know that you can send your patients in for lung cancer screening now. The criteria is they have to be aged 55 to 74, and they have to have a 20 pack year history of smoking. And lung cancer screening, the benefit of lung cancer screening is really that you're able to identify patients with lung cancer at an earlier stage. So it's essentially down staging, because we know the mortality for lung cancer when you have stage 4 disease, which is when it most commonly is diagnosed at the moment. The 5-year survival there is only about 5%, whereas at stage 1, the 5-year survival is 75% or 77%. So catching people earlier really makes a big difference in terms of survival. I don't know if we got any more guesses coming in. Starting to come now. Okay. The other benefit of lung cancer screening is it's twinned with a smoking cessation program. So you sort of catch patients at this vulnerable moment when they're realizing the potential implications for their smoking, and you sort of have a captive audience there, and smoking cessation in this population tends to be much more effective than as a whole. Okay, so we'll leave it there. The correct answer is actually 250. So if your patient comes in with it's a woman, she's coming in with breast pain, what is the chance that she has breast cancer? What percentage of patients come in with breast pain and are diagnosed with breast cancer? So we've got varying guesses here. So breast cancer, again, most women present with lumps, but we know that we've often been told that not a lot of patients that had pain had breast cancer. So I think a lot of family physicians tend to, if someone has pain, kind of assume there's not a breast cancer. Certainly, let's see, I think we'll leave it there. So the correct answer here is actually 6%. So there is a group of women who do present with breast pain that have breast cancer. So this is a topic that I find really difficult for family physicians, because you'll notice that your mammograms have started to include breast density. So the question is, what should you do when your patient's mammogram comes back as BI-RADS 1, but ACR D? So American College of Radiology D, breast density, or extremely dense. Should you continue with regular screening? Should you do MRI? Should you do supplemental ultrasound? Should you do a yearly mammogram and look at their lifetime risk with the Ibis calculator, or none of the above? So we know that breast density is in and of itself a risk factor for breast cancer. So the reasoning behind that is twofold. So number one, mammograms are not as effective in extremely dense tissue because you can't see the tumor beneath the breast tissue. And number two, having dense breasts actually increases your risk fourfold of developing breast cancer. So it's a risk equivalent to having a first-degree relative. So the actual, what you should be doing for these women is you need to put them on a yearly mammogram schedule as opposed to a biannual mammogram schedule. Supplemental ultrasound is not covered by OHIP for these women. However, if you're really concerned, it is something you could think about doing. And really you want to use the Ibis calculator, which is if you just Google Ibis calculator online, it's a tool that looks at risk factors for developing breast cancer, including breast density, that will help you figure out if your patient is high risk, and if they're high risk, you can refer them to the OBSP high risk program. So if you have a patient with a bone met and you give them a single fraction of radiation, what percentage of those patients will the pain totally go away? Is it in 10% of patients, 25, 50, 75, 90? So radiation is something that often family docs don't know a lot about, but it's got a lot of indications for palliative care, where you can often give 1 or 2 fractions and really quickly have good symptom control. And so I think we still, the correct answer here is actually 50. So half of your patients that you give a single fraction of RAS to will have complete resolution of their pain. 80% will have some resolution. So it's a really good tool to know about in your toolbox. This is an interesting one. So you have a woman in your clinic, you diagnose her with metastatic breast cancer. She asks you how long she has to live. What do you say? 6 months, a year, 18 months, 2 years, 5 years? So we got a bit of a split here. Okay, so the actual answer is actually 5 years, which is really incredible when you think about it, that a metastatic cancer, that's your kind of average survival. But the treatments for metastatic breast cancer have really improved over the last several years. And often what we're talking about for treatment here is not chemotherapy, but an oral medication twinned with a hormonal therapy. So that's actually pretty amazing, and I think really helpful to let your patients know. And last question here. So your patient goes for radiation therapy for his prostate cancer. You're monitoring his PSA post-treatment. How long does it take for the PSA to reach its nadir after the radiation? So you're watching this. How do you know when it's sort of he's at where he's going to be? Okay, so varying answers, but the actual answer here is actually 3 years or 36 months, which clearly we need, based on the answers I'm seeing, I think as family docs, we're not necessarily well supported to support our cancer patients, right? You're supposed to be following that patient post prostate cancer treatment, but it's not even clear, what the PSA kinetics are often. So I'm just going to run through a few of the initiatives that I've done to help FPs increase their cancer IQ. So you can see kind of what resources are out there and what's moving forward. So some of the things I've been working on, a webinar with the college, demystifying breast cancer. It's still available on YouTube. You're welcome to click on the link. It's an hour webinar that goes through everything from diagnosis, screening, treatment, and survivorship care of breast cancer. I've been working with the college and the Cancer Care Member Interest Group to develop online modules for education that are going to be in the CFP Plus learning portal, so you'll be able to access those. Many of you saw the breast cancer survivorship tool that I presented back when we could have in-person conferences at the Montebello. So this is something that's available in the CFP. If you Google it, you'll be able to find it online. This is the initiative that I'm most excited about at the moment that I've been working on. It's called Oncology Briefs. So this is a series that I'm working on with the Canadian Family Physician Journal. And I have an agreement with the editor of the journal to do a quarterly series of 17 articles that cover basically all of the key oncology topics that family docs should know. So starting from screening, the most recent one that just came out this month is diagnosis. But the plan for this series is for it to go through treatment, survivorship care, complications of treatment, all those kinds of things. So be on the lookout for this series. You'll be seeing it 4 times a year. I'm working with a group of docs that I put together across the country to produce these and kind of review them. And so it's a really exciting initiative because it's a way to kind of frame a lot of this oncology knowledge from a family medicine perspective and make it relevant to family docs. The last thing that I'm just taking on as regional cancer primary care lead. And in this role, what I will be doing is being the link between family medicine and the Champlain LHIN. And so I'm really keen starting out on this to increase communication about cancer care to family docs, to look at how the system can work better for family docs, and to allow family docs to put input back into how they want to see the system run. I'm also keen to keep going with educational initiatives because, clearly, as we've seen, those were just a few topics that I picked today for the cancer IQ, but there's lots more that's important, I think, for family docs to know. I've put a link to a survey here. I'd love if you would take the time during this presentation or afterwards. There's only 3 questions on there. Really just asking, what would you like to see different about the cancer system? What cancer topics do you feel like you need education about? How comfortable are you with your oncology knowledge now? So if everybody can click on that link, and I don't know if maybe it can be put in the chat as well so that it can be clicked on easily, that would be really great. The other thing that's requested in that survey is your email. So if you would like to be added to the email list that gives a lot of updates right now coming from things like cancer screening or new programs, changes with cancer patients and COVID, you could be put on that list as well. So please take the time and click on that link. So that's all I had to say today. It's a very brief overview of what I've been working on in terms of knowledge translation. I'm really keen to get your feedback. You can also just email me directly at my TOH email if you have questions or input for the cancer system. So thanks very much. I'm happy to take questions.
Anna, thank you very much. That was a great interactive presentation. Well done. And congratulations on your oncology brief series as well. If you haven't caught it, everyone, even last week's edition in the CFP, you can see it. So we have time for like one quick question, and then because we have two other presentations this morning. So if you have a question, please just put it in the chat or just raise your hand. Dr. Liddy.
Hi, good morning, everybody. Congratulations, Anna, on your work. And I think this is a fantastic example of how, as a family doctor, an academic family doctor, you choose an area of focus, of passion, and then work it through in terms of making contributions that are having an impact not only locally, but also on the provincial and national level. So I think the examples that you've shown, your very methodical approach are just fantastic. And if Anna hadn't done this type of work as a family doctor, we wouldn't have all of these amazing tools. So congratulations.
Thanks.
Okay. Well, thank you. I'd like to now move to our next presenter, and that's Dr. Michael Malek. Dr. Malek obtained his family physician certificate in 1997. Practiced as a solo physician for 10 years. He moved to the Ottawa Hospital Academic Family Health Team in 2008 and is currently a staff physician and preceptor for family medicine residents. His clinical interests are in geriatrics, long-term care practice, and palliative care. He's a postgraduate residency director at the Civic Campus since 2018 and is currently completing a Master's of Education in Health Professions Education at the University of Ottawa. So Mike, I turn it over to you.
Thank you very much, Doug. You can hear me okay?
Just fine.
Okay, now this is where my non-Zoom literacy comes to play in terms of starting the slideshow. I'm not seeing my slideshow start. Oh, let me see here.
Do you have multiple screens? There we go. Perfect. Yeah.
There we go.
Go ahead.
Okay, welcome everyone there. So let me just minimize everyone's heads there. Okay. So welcome. Given this is a very weird, challenging time, I'm going to do this in reverse order here. I'm going to start off with the acknowledgements here. So this exciting project that we started a few months ago could not be done without a team effort, which is why the team is on the as the lead on this slide. So the gang on this slide is just some of the people that made this fun project work. Special shout out to Jason Trickovic, who also was one of the leaders of one of our sessions. Dr. Will Torton, who is just with his extraordinary imaginative mind, who really was the pioneer of all this, as well as the behind the scenes folks, Ashley and Melissa, who also got this off the ground. So so our family health team, we had undertaken a unique initiative in an attempt to address this pandemic-induced isolation and risk of burnout faced by our residents and our staff physicians. So, you know, our world was turned upside down, and the shift to virtual care and resident training led us to profound social isolation and a lot of symptoms of burnout that we were noticing in our clinic. And so with this atypical study, and certainly atypical times, the purpose was to try to identify these concerns and possibly enhance connections amongst learners and the faculty, and hopefully improving wellness in the process. So we all interpret burnout in various ways. So with this actual survey called the Maslach Burnout Inventory, or MBI, it's a psychological tool with 22 symptom items pertaining to occupational burnout. So the three main dimensions of burnout that are measured in this tool include emotional exhaustion, depersonalization, and reduced personal accomplishment. In our teaching environment here, the pandemic, and this is not unique to us, of course, the pandemic resulted in disruptions to resident training, canceled clinical experiences, virtual care being done most of the time, indirect supervision by preceptors. And sadly, the social component for the residents and their ability to foster new relationships and friendships was significantly impacted. So using a social learning theory as well as a community of practice model, we attempted to focus on the strategy that promoted wellness as opposed to mainly just focusing on ways to reduce burnout. Not to mention that a lot of the issues were outside of our control, given the pandemic. So we launched this exciting event called Free Food and Fresh Air Fridays, which is a COVID-friendly event. So it included a free lunch and typically a very fun activity ranging from an escape room challenge led by Dr. Will Thornton, which was incredible if you want to rent him out for birthday parties or bar mitzvahs. So we did it across the civic campus. We also played an online video game of Among Us led by some of our residents, trying to focus on the topic of imposter syndrome. And Jason Trickovic also sort of led us through a fun exercise in mindfulness. So a couple of fun items here. So our version of CCC in this unique study was more of an approach to focus on these 3 C's, focusing on community, getting together, having some free food, conversation about the weather, the pandemic, or sports, or medicine perhaps, and then connecting with each other with this, with the unique activities that we had on a monthly basis. So here's a couple of our keen staff working against the clock in the escape room challenge, and also our poster advertising the imposter syndrome video game that we had, that we played online. So with everyone with a free lunch in hand, participants completed the anonymous survey, which was the abbreviated Maslach burnout inventory. So the scores were then analyzed by group over time. So the different groups were faculty, PGY1s, and PGY2s. And this particular shortened inventory used 9 questions from the original version, which had 22, again, focusing on the 3 principal domains relating to burnout. So depersonalization, emotional exhaustion, and low personal accomplishment. So here's some of the questions that were posed to the participants, and then we collected this information in electronic format. So with the 9 questions, there was 3 questions per domain, and the scoring was attributed to the 3 relevant domains. So we had tremendous monthly participation, and the overall results demonstrated a little bit of a concerning trend, especially pertaining to emotional exhaustion among the residents. The narrative comments were also solicited and were very overwhelmingly quite positive regarding us performing these sessions. So on the first slide here, the depersonalization domain, there was a little bit that was highlighted amongst residents and staff in this survey, but thankfully only a few times per month on the 3 questions pertaining to this domain. And this is the one that showed the more informative data showing that there was some increased emotional exhaustion among residents, more so than the faculty physicians. So for example, feeling fatigued when they get up in the morning and have to face another day on the job, emotionally drained from my work. So those were ranked as happening quite often over the course of a month. And thankfully, the scores were a little bit higher on the personal accomplishment question, so higher the better in this domain, showing that at least people were feeling effective dealing with the problems of patients in their clinic. So another important element in this study was the data collection, and the narrative comments also told us a bit of a powerful story. And that was that addressing and supporting residents during these difficult times was critical. It was well received, and you can see this by the many comments that people were quite willing to show during the survey. So keeping these events going, they're very supportive, really brought people together, lots of laughs, lots of smiles behind their masks, and love that it brought the team together better. Great idea, highly appreciative. We really did not see any negativity in these responses. Of course, food always helps. So in terms of some of the limitations, it was a bit of an atypical study. So we had a small sample size, and again, being in our residency program, there's going to be changing participants month to month. And could there be a variation based on the month that it was done, changes in the pandemic, and is it a true cause and effect? So it sometimes can be a bit of a stretch to say that indeed our endeavor was actually making a difference. But again, the focus was more to promote wellness and just to identify if there were issues pertaining to burnout. So, I mean, as I was mentioning, these were very well-received gatherings, and I mean, I make a joke about the food, but food is quite a popular thing to sort of bring people together, many have commented that in previous studies that it does potentially enhance wellness. And other studies also, again, support the fact that monitoring for burnout can be an approach to supporting wellness. And we identified that in this study, especially in the residents, that we did notice, especially on the emotional exhaustion components, that there were higher levels in the PGY1s, which perhaps is not surprising given they're new to residency in very challenging times, high responsibilities, and not much control over what's happening during their day. And the comments were, again, very useful for us in terms of ways that we could attempt to improve on their wellness. And some of their suggestions, actually, we took them and made some tweaks in our booking, for example, of our patients. And again, lots of other studies in the past pertain to surveying wellness and burnout risk in residency. The two that I've highlighted here are focusing on family medicine residents, and that conducting wellness curriculums can lead to improved scores and improvement potentially in burnout. So in conclusion, this innovation in our little world here, during these atypical times, it identified how the pandemic has resulted in widespread disruptions to our community of practice. And despite our low sample size, the trends that we noticed were a little bit concerning for resident burnout. And with this initiative, the comments that we got from the participants were also extremely telling. They conveyed appreciation for our efforts at supporting our learners during these times. And while enhancing the wellness, we've noticed that it did have an impact in the weeks following some of these events. And there's some of our references today, and that's our presentation. Thank you.
Mike, thank you very much. Terrific to see this being presented and that you're applying social learning theory. Well done.
Thank you.
We've got a couple minutes for questions. Dr. Seal, I see you have your hand up.
Hey, Mike, how are you doing this morning? That was fantastic. Really, really well done. Well, excellent. And I mean, I've been getting feedback from the wellness office about some of our struggling residents this past year. And this is just amazing to hear this stuff that you've done. And two things I'm wondering, is this, number one, how do you think this could be spread out across the Department of Family Medicine itself? And do you think, I'm not saying that this is a one size fits all approach, but do you see this being something that could be done that way? And secondly, has this information been fed to the wellness office, Dr. Mugga? So I'm just curious, because she'd probably really appreciate having this kind of data.
Thank you, Ed. Actually, I apologize actually for not mentioning in my introductory acknowledgements, actually the department itself. This would not have happened, of course, without funding from the department. So actually you are already participating in this. And I think it's an excellent endeavor that could be tweaked for each individual environment, and probably should continue even when the pandemic is over. And showing that we care, and I think it goes beyond our pandemic. So you're already showing the money. So keep it up, and the support, of course.
Okay. Do you have a question? Just put your hand, or just note in the comment. And if not, thank you very much, Mike. And I'm now going to turn things over to our next two speakers after I introduce them, of course. And that's Dr. Leah Smith and Jason Trickovic. So Dr. Leah Smith is a full-time academic family physician at the Ottawa Hospital Academic Family Health Team at the Civic site, and her clinical interest is in providing holistic family medicine care, and in particular, providing excellent person-focused care to our aging population. Dr. Jason Trickovic is a medical graduate from the University College Dublin, after which he completed his family medicine residency at the University of Saskatchewan. After his family medicine residency, he completed an additional year in emergency medicine and practiced in both Saskatoon and Meadow Lake. In Meadow Lake, he practiced full scope family medicine and held role as the emergency department director. Upon his return to Ottawa, he joined the Queensway Carleton Emergency Department as a locum staff, where along with other frontline workers, dealt with our most recent COVID pandemic. Recently, he's now joined the Academic Family Health Medicine Unit at the Civic, where he's heavily been involved in the new long-term care initiative. He is excited to be back in academic family medicine. His teaching is a great passion of his. He's interested in point of care ultrasound and his future role in family medicine. So without further ado, I turn it over to Jason and to Leah.
Hi, everybody. My name is Dr. Jason Trickovic, and I'm one of the physicians at the Civic Family Medicine team. Today, I'd like to present to you an exciting initiative, academic initiative of how we are incorporating long-term care into the Civic curriculum. I'm presenting alongside Dr. Leah Smith, and we've titled this talk today, The West End Villa Experience, a long-term strategy for long-term care. So first off, we have no disclosures, both myself and Dr. Smith, to declare. And maybe I'll hand it over to Dr. Smith just to go through some kudos.
Yeah, so hopefully everyone can hear me okay. Just sort of before we get started, the context for all of this is that a group of 5 of our academic physicians at the Civic Riverside Academic Family Health Team have taken on patient load at West End Villa, which is a long-term care home in the west end of the city. And this is a complement to our usual full-time family practice. It's new for all of us. And so the purpose of today's presentation is to discuss specifically the educational aspect of the project. There have been a ton of people that have been involved in this thus far. This is a group of people that have been either on the ground at West End Villa, organizing from a more departmental high level, and or contributing their expertise in medical education. But the list is probably longer than this. So anyway, we thought it was important at the beginning to acknowledge everyone involved.
Thanks, Dr. Smith. I'll mute myself again here. So we had 12 minutes. Hopefully now we probably have 10. So I just think it's really important for everybody to understand where we're going in this presentation. So we're going to take a little bit of time to present the why of why we've tackled this initiative. Then we're going to get into the program itself, and then we're going to have some thoughts around how we're going to track success. So first, the why. Well, to speak frankly, we had a little bit of a blind spot in the curriculum. We did an audit with some of the staff, and while everybody was very positive in saying that we had exposure to the care of the elderly through inpatient medicine, palliative care, home visits. We kind of figured out as a group that we had no unified experience to bring all these competencies that our residents were learning into one kind of more community-based practical setting. And, we all saw long-term care as fitting that gap. This was actually supported, believe it or not, our staff our thoughts was supported by an informal survey that we did with the Civic and Riverside residents. And it showed that 17 of 18 of the residents that responded to our survey had no direct exposure to long-term care. And 50% of those residents, so a large part of them, had low interest in working in long-term care as part of their future plans. It might sound dire, but we're not alone. Both in North America, there has been fewer and fewer FM residents that are choosing long-term care and associated training. There was a study, it was pretty much a survey done by Res et al. It was piggybacked on top of the CIRA study and essentially it was a survey of all the US family medicine program directors and trying to identify what the implementation and barriers were to introducing the long-term care curriculum and future interests amongst their residencies. And while they all said they had good long-term care experiences, they all noted that there was very low pickup of their residents going into long-term care. Locally, anecdotally, I've heard that we are having a little bit of a lag in people applying for and completing the PGY3 care of the elderly and palliative care fellowships, which can maybe be a little bit of a proxy to what we're seeing in long-term care. To put a little urgency around this initiative and the importance of long-term care in our curriculum, we are seeing that in addition to an aging population, there's an aging workforce where a lot of the physicians that are delivering long-term care are actually nearing the end of their practice, and there's going to be a vacuum at some point, and we are going to have to fill that with the importance that we've all noted. It's important to note that the CFPC is aware of this too, and it does appear that there will be increased focus in long-term care in their position statement coming up related to the practice, the discipline of family medicine. So internally, we saw that there was a need. Obviously externally, we saw what COVID done to our vulnerable population in long-term care. Specifically at the West End Villa, we had over 100 cases, multiple kind of outbreaks, and unfortunately had 20 patients that have passed away since March of 2020. TOH came in, they helped, not I would say with management more, but more with the provision of care. And we were allowed to or be part of this opportunity, which led to this teaching opportunity. In reading some of the literature and kind of preparing for this talk, I stumbled across an editorial at the CFPC, and I thought this quote kind of brought together exactly what we're trying to do here. So when you transform the learner, you transform care. And I think that speaks to the two kind of needs that we spoke to, ours and the community in which we serve. And I think if we really want to affect care in our community, we're going to have to start at transforming the learner, which means kind of thinking about innovative initiatives to increase their experience and their desire to do long-term care. Brings us to our goals. Our goal of this academic initiative is first mainly to expose trainees at our site to the long-term care setting in order to build on the competencies that they have from other exposures, and help them use those competencies to provide care in the elderly population in a community setting. More importantly, we wanted to really have an aspirational goal, and this is years out, and we want to use this to increase the number of graduate residents that choose to practice long-term care. So it's a little bit of a lofty goal, but I think an important one based on what we've all heard. We also wanted to make sure that through improving diversity in our practices, our physicians would maybe have a little bit more job satisfaction. So with that, I'll turn it over to Dr. Smith, and she can kind of run through the program.
Yeah, so you can go to the next slide. Everyone hear me okay? All right. Take that as a yes. So to begin our process of designing an educational experience, we formed a working group of 7 physicians and reviewed some very limited literature on developing such programs. So there was a cool article by Oliver out of McMaster in 2011 that described a long-term care curriculum. And after that, not a lot. And some of our key priority decisions were listed here. So what were our core competencies or educational targets going to be for learners? What would be our learning strategies? So would we focus more on formal teaching like didactic sessions and modules, or would we be focusing on experiential learning, ad hoc teaching, case review model, that sort of thing? We discussed a lot how we would expose learners. So would they come and do one block during their family medicine residency with us as a big chunk, or would they come in little bits and pieces longitudinally over time? And last but not least, call is always a big topic of discussion. Go to the next slide. So this is what we've decided for now. Obviously, this is all moving target at this point. So currently the plan is that residents will be attending West End Villa for 1 half day per week. during the duration of a regular family medicine block, twice during their residency, and this will be with an assigned preceptor. During that time, they'll participate in care of their preceptor's 20 to 30 residents. Go to the next slide. Learners will participate in all aspects of patient care, including rounding on residents, family meetings, and also participate in the ministry mandated areas of care. So that would be quarterly medication reviews and annual health reviews in particular. Go to the next slide. We spent some time trying to outline some core competencies or learning targets for this group. Most of them are pretty self-explanatory, but I do want to draw your attention to the last bullet, which emphasizes the importance of learners gaining an understanding of the uniqueness of the long-term care setting. So this encompasses both a familiarity with ministry standards, as well as the general approach to patient care, which is person-focused, which is a little bit of a nebulous concept, but essentially it's a concept of caring for the whole person over time in their context, with an emphasis on their lived experience. And this is obviously difficult to explore in our more traditional inpatient and even ambulatory care settings, which are by definition episodic. But it is an approach to care which we feel can be sort of applied across all domains of medicine. Yeah, we can go to the next slide. I'm not really going to get into this. I think that all of us that are trying to accomplish anything in medicine at this point have hit barriers when it comes to COVID, and we just keep carrying through and doing our best.
Hey, thanks, Leah. So I'd like to talk a little bit about how we're going to track success with this initiative. You know, both Dr. Smith and I have been speaking to a lot of the faculty, and, you know, we've stumbled across many times how a logic model is going to be very important for us reaching our outcomes that we've identified in terms of our goals. You know, unfortunately, you know, we've been thrust into this position where we've really kind of jumped in, and a logic model is not completed. We hope that through this presentation and any feedback you have, we will be able to feed that into this and have something a little bit more concrete in the upcoming months. It is an iterative process involving a lot of different stakeholders. So this is perfect for us, and also, you know, is going to change over time. As I mentioned, though, we have been kind of thrust, both Dr. Smith and I have started rounding at this facility in late January, and we are planning to have residents next week at the site. So it was really upon us to think about assessment and how we were going to start to at least track our residents up the continuum from just having a feel-good moment with long-term care to actually practicing as long-term care physicians. So this is the Kirkpatrick model. It's what we're using to kind of to map our formative assessment. And to people that maybe are not involved or have not seen this before, it's really trying to you know, map your assessments at different stages of a learner's kind of development towards your goal. And for us, at the top there is our goal of having an increased physician workforce practicing long-term care, but also producing capable residents able to practice independently in long-term care. So intuitively, a lot of what we do when we have programs is and do assessment. A lot of those things we're going to be doing because there's a lot of really useful feedback to that. And we will be doing the traditional competency self-assessment surveys. We will be obviously doing field notes and, you know, under direct observation. We will also be trying to get at the satisfaction engagement piece early on so that we can course correct and make sure that people are having at least a very feel-good experience with this off the bat. I don't think I have time to go through this, but when we look at the self assessments, we are going to be using a post-pre survey design, and we are going to be adding a little bit of a confident interval to it to see just the depth at which they feel more comfortable. These competencies and attributes that we have here are just pretty much, we've filled them in, we've truncated them. They don't represent our curriculum at the moment. Partnered onto these self-assessments after each block, we are going to do a qualitative survey component, which is going to get at some of the engagement stuff. And that's going to be done with both staff that are participating as well as the residents that are participating in that, to get to that, first level, level 1 reaction, and really have some early feedback. It may become apparent, it became apparent to Dr. Smith and I that the challenge with this is that, we are really not assessing behavioral change. And through talking with many of the faculty, this seems to always be a challenge with a lot of, learning initiatives. But we saw that there was a gap. So, it's not surprising that this gap exists. As I quoted in that previous study, that US study, there are a lot of barriers through giving a good long-term care experience program and getting people to actually practicing. And so we wanted to think about moving forward exactly how we're going to track that. And it becomes a little bit non-traditional. And again, this is where feedback from our greater kind of academic unit would be very helpful. We are thinking about monitoring what we think are leading indicators towards behavioral change when it comes to the adoption of long-term care into a practice. Specifically, we're going to be looking to see if there is an uptick in the PGY3 applications for both care of the elderly and palliative care, understanding that they're proxies and they're not exactly long-term care, not a perfect unison with long-term care, but some of the same characteristics. We are going to be monitoring to see if there's a pickup in long-term care extracurriculars, such as courses and conferences that are involved in long-term care. We are going to be looking for if there is an appetite or an increased appetite for mentorship, because we feel that people seeking out mentorship means that people are thinking ahead towards potentially, the nuts and bolts of practicing as a long-term care physician. We also are going to be tracking to see if there is an increase in the focus, the long-term care focus in both the QI projects that are coming through our department specifically, and the scholarly projects. So again, these are, leading indicators, not perfect proxies, and we welcome any feedback as to how we may be able to really get at the behavioral change piece so we can move people into long-term care eventually through our initiative. So with that, I'll turn it over to Dr. Smith, and she can just summarize our talk here.
Yeah, so I'll just sort of leave these slides. I think I want to leave a bit of time for questions and going through the chat as well. I think people sort of got our idea. I'm seeing a ton of conversation in the chat, which is really, really awesome. It seems like there's some similar projects occurring at Greystone, maybe in some people in Winchester doing this. Anyways, seems like there's a ton of people. So maybe Jason, you can just flip over to the next slide. And I agree with that. Dr. Ponka is 100% speaks to our values in FM. So, and a summer student. Wow, we're getting lots of great offers here. So I think maybe where we'll leave things before I open up for questions is, if you're one of these people in the group here that are interested in talking about this more, why don't you shoot me or Jason an email, and we can see if there's a way to set up sort of a more formal conversation to see how we can collaborate. If that works for everybody. But any specific questions that people have or comments?
Jason and Leah, thank you so much. That was a terrific presentation. So glad to see that you're building in program evaluation models into your work. And you worked in a quote from, or you've referenced Barbara Starfield, and a quote from Lynn Sonnenberg. She'll be thrilled. I'll make sure she knows that you did. So yeah, we do have a couple minutes for questions. I see there's 2 hands up. Dr. O'Shea, how about you first?
Hi, I'm one of the folks who's joined, and it's a whole new ball game because we're dealing with a different system, paper, charting, approaches, goals, philosophy, communication, referrals, culture, orientation, psychosocial history. So it's not just the residents who are going to need help, it's the preceptors to make this happen, because you can be a little bit awash here.
Okay, thank you, Owen.
Doug, I'll
Dr.
jump
Liddy.
in. Yep.
Sure,
Hi.
please do.
Yep. So I'm happy as the department. I've been thinking about sort of hosting town halls, community of practice, let's say gatherings along common topics. to bring all of the folks together. So if you want, I can take that on and we'll try to get basically, I think, like a quick, meeting where all interested parties across the different scopes, as far as we know, we can sort of generate that list and have an open call so that everybody can start sharing. So happy to do that. And then if you have a summer student or you wanted to try to think about that to help with some of the curriculum design or any of the evaluation activities, please do follow up. And that's an offer for anybody else as well. If you have a focused project and you think that you could achieve, one part of it could be, completed by a summer medical student, there is funding available from the department to support those activities. And congratulations to all of the speakers this morning on some fantastic work. Thanks.
Thank you, Claire. And David, good to see you.
Hi, I know we're out of time. I just really wanted to congratulate the speakers as well, and wanted to make the link between the two talks. I believe when residents talk to us about burnouts, there's a lot of cognitive dissonance right now around how they could get more involved in the crisis. And what a more perfect way than to show them that there's a way to assert our values in long-term care. So let's keep this conversation going. Thank you.
Good.
And with that, we're now at 9 o'clock. And I'd like to thank all the speakers today. Fabulous presentations, great interaction with our audience. I can see that we were up to 66, 67 people. So fabulous. Thanks for your participation. And I look forward to seeing you all next month as so the Primrose group that will be presenting. So thanks again. Have a wonderful day.